Hello, this audio lecture is going to be about the GI disorders found in Unit 4. The disorders that will be covered will be ulcerative colitis, Crohn's disease, irritable bowel syndrome, intestinal obstructions, including paralytic ileus, diverticulitis and diverticulosis, hernia, hemorrhoids, and colorectal cancer. The first topic is ulcerative colitis, and this is an inflammatory bowel disease. There's going to be edema and inflammation of the rectum and the rectosigmoid colon, um, redness, abdominal cramping, and pain in the left lower quadrant. I talked about in class, there's going to be belly pain with almost all these disorders, but it's defining where it is. In ulcerative colitis, it's the left lower quadrant. Fever, and this is also a big deal here. There's going to be diarrhea, and it's not just one or two. It's up to 15 to 20 liquid stools per day, and they will have mucus, blood, and pus, and therefore there will be some rectal bleeding as well. So some things to know nursing-wise with ulcerative colitis is, there's an increased risk of colon cancer due to the irritation of the bowel. They may need to be NPO or have TPN to give the bowel a rest. They want a high-protein, low-fiber diet, and that low-fiber diet is just not to irritate that very, reddened bowel. Avoid caffeine and alcohol for the same reasons. And also small frequent meals just makes it easier to digest, and obviously monitor for electrolyte imbalance due to this and the dehydration due to this massive amount of diarrhea that these patients have. Crohn's disease is the next inflammatory bowel disease, and like I said in the previous couple slides, there's ways we need to differentiate these diseases. So this is usually in the distal ileum, where the other is usually on the rectal end, and it can actually involve the entire GI tract, and there's going to be issues with malabsorption and malnutrition. So again, we've got the abdominal pain and cramping, but it's usually in the right lower quadrant. Fever, and then also diarrhea, but that's like 5 loose stools a day with mucus and pus, not the blood. And then also the fatty stools with a steatorrhea. So if you look at this slide, you might think, Brenda goofed up, and this is just the same slide as ulcerative colitis. Well, actually, we have most all of the same nursing care for Crohn's disease as we do the ulcerative colitis. They also can have an increased risk of colon cancer. They may be NPO or have TPN to rest the bowels. High protein, low fiber diet, and avoiding those irritants of caffeine and alcohol. Obviously, electrolyte imbalance and dehydration related to the diarrhea. I've had a couple of patients who actually ended up with ostomies for these diseases just because of the fact is the diarrhea was just so uncontrollable and affected their quality of life. The next disorder I'm going to talk about is a relatively new one, irritable bowel syndrome. Not new, it's been around for a long time, but it's actually called a disorder now. And it's kind of a cyclic chronic diarrhea, constipation, bloating, pain. They're really not sure why it happens, mostly in women. And they feel it could be, dairy products, caffeine, infection, anxiety, depression that maybe cause it. What we'll see in that is just cramping, kind of what we talked about above, bloating, belching, and it can be left lower quadrant pain. And it's very difficult to diagnose. Sometimes it's, people get this diagnosis when everything else has been ruled out. So again, that pain is in a little different location than it is with Crohn's disease. Same, as ulcerative colitis, and there'd be a differential there if the diarrhea was excessive and bloody, which would make you think ulcerative colitis. So the nursing care with IBS is obviously strategies to reduce stress, and we visited in class about sometimes it's not actually the stress but the perception. If there are things that irritate, make sure that those are eliminated from the diet. The diet should be high in fiber and fluids to help with the bulk, and then also if there's any constipation, may be very helpful to keep a food diary. You know, what is irritating? What are you eating that maybe sets you off? And then finally, laxatives, and or antidiarrheal agents will probably be used. Next, we'll talk a little bit about intestinal obstructions. And there really are two types, and that would be mechanical and non-mechanical. So if you think about it, mechanical machinery, it's going to be something that's actually causing the mechanism of the intestines not to work. For example, it could be adhesions, which are, scar tissue within the abdomen, generally from surgical procedures. Tumors, so if somebody has a large colon tumor, or perhaps they have a large tumor on their spleen. For example, one of our good friends had a benign tumor that was the size of a bowling ball, so that could be obstructing the intestine. And then hernias as well can do that. Non-mechanical ways that the intestine can be obstructed is just through diminished peristalsis, and this is what we call then paralytic ileus. So if we think about the word paralysis, just kind of a paralyzing of the intestine, which causes an obstruction. Some of the signs and symptoms include, obstipation, uh, belly getting distended, high pitched, or then eventually absent bowel sounds. And if the fecal odor of an emesis, that's telling you things are not moving on through, and you have an obstruction going on. And of course, nausea and vomiting, because the whole thing of being obstructed is going to make people feel pretty unpleasant. So the nursing care we're going to see when someone has an intestinal obstruction, NPO, because they want that bowel to rest. Plus, it would be dangerous anyway to try to be eating or drinking when there's an obstruction, because it's obviously not going to go through. We're going to assess their bowel sounds. Obviously, they're going to have some fluids if they're NPO. Pain management, semi-Fowler's position. Um, NG tube, and then really monitor for that dehydration. The two words at the top of this slide look very similar, but they are different. First of all, diverticulosis is the presence of these diverticula in the colon without inflammation. And they're just like little small pockets. And so they can be in the colon, but when they, kind of start to cause problems is when it becomes the diverticulitis, with the inflammation and infection of this bowel mucosa, of these little pockets that exist. You are going to have a client's going to have acute abdominal pain in the left lower quadrant. So again, there we have a location of pain, nausea, vomiting, fever, chills, and tachycardia. And for some of these flare-ups, this is actually an experience that they're going to be hospitalized for. So like I said in the previous slide, if it's a severe case, they're going to be NPO, they're going to have an NG tube, they're probably going to be on opioids for pain. And this is where they're going to be hospitalized and have some very severe symptoms. We're going to encourage them to be on a high fiber diet, and they really want to avoid seeds, popcorn, nuts, because they'll actually that will get stuck in those little pockets, and then it can cause some symptoms. And we really need to have measures to promote regular, normal BMs. The next thing we'll talk about is a hernia. And this is a displacement of the bowel through a weakness in the abdominal muscles into other areas of the abdominal cavity. So you may have an umbilical hernia. There are also, inguinal hernias down in the groin. And the main thing that we become concerned about is sometimes they can become strangulated, where the blood supply is cut off, and then surgery is definitely necessary, or these patients can get very ill and actually have some necrosis go on with that bowel. Sometimes people get incisional hernias. It can be a post-surgical complication. The causes include being male, as you get older, if you're obese, you're pregnant, and then genetics have a lot to do with it. Treatment If it's a small enough hernia or if it can easily be reduced, a lot of people will wear a hernia belt to kind of keep things in place, but very often a surgery is going to have to be necessary. Hemorrhoids are enlarged blood vessels near the rectum. They a lot of times happen from straining to have a bowel movement with pregnancy because of the added pelvic pressure. Um, Sometimes these are just, don't bother people at all. Some people have pain, pressure, and bleeding. There are many over-the-counter preparations that they can use topically to help. However, sometimes people have to have surgery for these to have them removed. And it's important post-op to keep these areas very clean. They're going to have sitz baths, which are usually warm water that just keeps the area clean. And we really want to have these patients keep their bowels soft to avoid any straining. So a lot of times they have to be on stool softeners, or we need to encourage a high fiber diet. The last topic in this audio lecture is about colorectal cancer, and this is cancer of the rectum or the colon. And one of the risk factors for this is a diet low in fiber and high in fat. This can actually be a risk factor for colon cancer. Also, a history of polyps can be as well. That's why we want to do these age-specific colonoscopies. So it's usually your first one after 50. And then we also, when people come in for their physicals after the age of 50, they need to have their stool tested for occult blood every year. Ulcerative colitis and Crohn's disease can be risk factors for this. And sometimes people, if they have colorectal cancer, they have to have a colon resection. Sometimes they have a colostomy and sometimes they don't. Pretty major surgery. They usually have a midline abdominal incision, and we have all the surgical care that we need to do with that. If they do have an ostomy, some things to keep in mind, and I know you as CNAs have worked with ostomies, but we want to, the sign of a healthy stoma is that bright red, shiny, body image is a huge deal, and acceptance, to think that they're going to have this ostomy pouch on them for the rest of their lives. And it's also important for you to know about ostomy care. Things like making sure you empty the pouch to keep it from weighing heavily. That can actually make it leak. Tape is okay to make a few small little patches if you need to on the appliance. It's important, to watch that peristomal skin, but also not to use any moisturizers or lotion or anything, because then things just don't really want to stick in regard to the appliance. So in conclusion, this was the audio lecture on any GI disorders. We'll also be doing some work in class about these various disorders. If you have any questions, let me know. Thank you. Bye-bye.